I'm Alan Irvine. I'm the president of the International Eczema Council. It's my pleasure to welcome you to this session, which is a joint, in many ways, Alopecia Areata, Atopic Dermatitis, similarities, differences, learnings, what we can translate back into clinical practice. And it's also a joint meeting in the sense that we have a lot of patient partners here who will be filtering in too. We've got some here already. You're super welcome. That really makes the meetings very worthwhile, and we're going to have more patient partners after the break. So I'm going to do just a few introductory remarks about the IEC, and then I'm going to hand over to my co-chairs, Emma, Benji, and Robert, who are all here. So briefly, let me tell you about the IEC, since you're a captive audience, and you have to listen to this to get to hear about anything else. So today's meeting, it's going to be recorded. We post all our information, all our educational sessions are free on our YouTube channel. Encourage people to go and watch them, download them. They're up there for posterity, and they get access a lot globally, particularly for people who aren't able to travel to meetings. They've become very popular. Alan Stiles is here, and if you have any concerns or queries, interest in the IEC, if you want to join, if you want to partner with us in any way, contact Alan as your first point, and then he'll get you in the right direction. We've Josephine and Jennifer are also here, our administrative staff there. I think they're out in the hall, so you can catch up with any of our staff. This is what the IEC looks like. I'm coming towards the end of my second year as a president. One of the key things was really to drive global representation a bit more. So we have 37 countries now, a few more coming on board, and 181 councillors and associates. So the councillors are people, largely household names in their countries, well-established researchers in atopic dermatitis. Associates are younger, up-and-coming researchers. Associates do convert to councillorship after providing more kind of work and establishing themselves more deeply. We're a little underrepresented in South America and in Africa, but we're pretty well represented in our donut getting around the world. We're trying to push this hard to become more represented. So you can apply, and encourage you to do if you think you might be an associate or a councillor, and join the journey. We now welcome PhDs. Originally it was just dermatologists, then we extended to dermatologists plus allergists, and now we have PhDs. If you've got a track record in research that advances atopic dermatitis, whether it's bench research or epidemiological research, health systems research, but if you have a strong record in atopic derm, we want to have you to increase our expertise on our offerings. So we have a few things here. We have a mission, a vision. The vision is really to transform the lives of people with atopic dermatitis. Our anthem is we're a global community of leaders in atopic dermatitis research, treatment, and prevention. And our values, we're patient-centered, innovative, evidence-based, globally inclusive, collaborative, and forward-looking. That's what we are. In terms of our educational impact, we're celebrating our 10 years. You'll see it on the logo, the 10-year centenary. We've done 47 symposia. This is our 48th. 152 different unique speakers that we'll add to that today from 27 countries. So we're trying to be as truly diverse and representative as we can. We have more than 100 hours of free content. Encourage you to go and look at those on YouTube. This is our upcoming symposia slate, just recently finalized. We'll be in March at the AAD, we'll be at the SID in May in Chicago. We always do RADLA, that's our South American colleagues run that. We don't have the symposium title for that, that'll be in May. We haven't finalized our symposium title for Istanbul. We're in the ESDR in Heidelberg, and we'll be at the EADV in Vienna next September. So we've got a busy 2026, 6 meetings. The first meeting is psoriasis versus atopic dermatitis. When the script gets flipped, people who have AD get psoriasis under the pressure of certain therapeutics and vice versa, and it's really exploring the molecular and clinical implications of that immunophenotypic switch. That should be a good meeting. People who have suggestions, things that you'd like us to explore in our symposia, you're welcome to suggest those. We have a research committee that does due diligence on everything. So I would strongly encourage people to make suggestions. That's where these types of meetings like today come from. We're active in social media. I think LinkedIn is probably our most familiar channel now, but we're also on Facebook, X, and we mentioned YouTube earlier. And this is YouTube. We're really fortunate with our sponsors. We have a wide range of sponsors, most of whom are also sponsoring the ISDS. So thank you to those of you who haven't met and had the chance to thank already. You make everything possible. All of our educational programs, all of our research, all of our position papers relies on sponsorship, and it's super welcome and very much appreciated. So you can scan and access our program guide here. And then I am going to introduce Emma Gutman, who needs no introduction, from Sinai, just around the corner. Emma's a world leader in atopic dermatitis research and now leading some programs in alopecia areata, which you're going to hear about today. We've got Benji Unger, also from Mount Sinai. And you can read Benji's CV here. Again, a really dynamic researcher. We have Robert Bissonnette, who's a former president, like Emma, of the IEC and a leading clinical researcher in inflammatory skin diseases. Nice paper in the New England just last week. So it's nice to have all three of you up, and I'm going to hand the stage over to Benji, Emma, and Robert. Robert? Where's Robert? Okay, I'm going to hand it over to Benji and Emma. Yeah.
So hi everyone, we are really excited with this joint symposium on atopic dermatitis and alopecia areata. We now know that there are many more commonalities between these two diseases, and I think this can improve not only our understanding of alopecia areata, but also the way we treat alopecia areata. And you'll hear today from many patients. We have around 10 patients, both adults, about half and half, adults and children, that will talk to you about their experience and how it was for them to participate in clinical trials, some of them. And with that, I want to introduce the first speaker, Benjamin Unger, that is now also a counselor of the IEC. But for those of you that do not know, Benji is the director of the Alopecia Center at Sinai. So at Sinai, we developed a unique center for alopecia that has three missions. Not only to expand research on alopecia areata, but also expand clinical trials and also the clinic and seeing many patients with alopecia areata. We currently have patients coming to see us from literally all over the world, including Hong Kong, many places in Asia, South America, Europe, and others. And I think we are the leaders also in clinical trials in alopecia areata. Our numbers in all our clinical trials, when we take them, we don't take all trials, but when we take them are really high. So with that, I want to invite Benjamin Unger, that by the way is the first author in a paper that we are very excited that already came out, but it's not yet available to download in Nature, that also Natasha is part of it. So we were tasked to write the Nature review on alopecia areata. It's already online, but I think the download will be available in a few weeks. It's possible to download? Yeah, so you can download. We are very proud of this publication that includes some of the concepts that are presented here. So without further ado, Benji will speak to you about the epidemiology of alopecia areata and atopic dermatitis.
All right, so while I'm speaking, we'll sort out that issue. So we'll jump right in. Here are my disclosures. Okay, so hopefully too much of an introduction is not needed. Alopecia areata is an autoimmune disease in which a loss of hair follicle immune privilege, for reasons that are yet to be identified, causes an inflammatory attack on the hair follicles. It's non-scarring, and there's an unpredictable prognosis where patches of hair loss can come and go, and then at any point potentially progress to full or more severe scalp and total body hair loss. Very, very importantly, when we think about really every aspect about alopecia areata, It's associated with a tremendous emotional and psychosocial distress. This is really not a cosmetic disease. It really has tremendous impact on people who suffer from it. There's a wide range of different clinical presentations. Here are just a few. The epidemiology really varies quite a bit based on study methodology, area of the world, and so I think what we do is try to put together different pieces to come to a kind of an overall view of what's happening, and not really necessarily focusing too much on one individual study, but collectively getting a sense of how common this is, what kind of diseases are associated, and so on. With that said, overall the estimate is that there's about 2% lifetime risk, and getting to that point again is a combination of different studies that really converge to that. So here, lifetime risk of about 2%, incidence rates, something in the range of 20 per 100,000 years in some studies, and so on. It's most common in the third and fourth decades of life. Depending on the study, again, we see different peak ages of onsets, maybe a little earlier, but typically before age 40, although it certainly can affect people older than that. By distribution by gender is roughly speaking about even. Some studies suggest a little more common in females, some a little more common in males. I think the fact that there is this sort of disagreement suggests that if there is a bias, it's small, and largely speaking, it's about evenly distributed. A number of studies have identified higher rates in non-whites, so in the US and in the UK as well. In the US, African Americans are almost approaching twice as likely to have alopecia areata than white patients. Asians less commonly in the US, although higher in the UK. So again, I think further studies are needed to fully characterize what the distribution is across different populations. This was a systematic review and meta-analysis that I think demonstrates pretty well kind of estimates of how common this is. And so this is a pool incidence that, again, is converging to that 2% approximately, though in some areas we're seeing almost as high as 5%. The prevalence is also increasing. So this was a study looking at relatively recent data where alopecia areata is slowly increasing in prevalence over time, both among children and adolescents and adults as well. And we see a pretty similar trend with the most severe versions of alopecia areata, totalis and universalis, again, across different ages, sexes. Overall, it's increasing. Most of the studies estimate that pediatric alopecia areata is maybe a little less common. As we noted, the peak incidence or age of onset is early adulthood. Estimates around 14 cases per 100,000, peak incidence occurring 9 to 12 years of age approximately. Similar to what we've seen with studies focusing on adults and kind of the general population, there is a little disagreement at times in terms of boys versus girls. Some studies, again, suggest maybe a little more common in girls and then higher in non-white populations. The general thrust of this talk is that strong link between atopic disease and alopecia areata, and in the pediatric population, certainly AD is the most common comorbidity. At least in some studies, odds ratios approaching 10 times more likely. There are other associations as well, various autoimmune diseases, but the strongest one is alopecia areata. Is atopic dermatitis. And here are some of the other ones listed. The other ones listed here are associations that can be seen as well. Risk factors for alopecia areata are reasonably numerous, but perhaps not surprisingly, atopic disease, which I'm focusing on here, is probably the most concrete, well-characterized, and strongest association for risk of developing alopecia areata. And I'm going to show a number of kind of numbers and slides here that really hammer that point. I'm not going to read every number. The point here is that multiple studies getting different estimates, again, depending on methodology and location, really showing a greatly increased link between AD in particular and alopecia areata broadly. There's also other supporting factors with this link, whether it's biomarker data, efficacy of type 2 inflammatory targeting agents like dupilumab. Dr. Gum is going to speak more about this, so I won't go too much into this. There's also a genetic link. So one of the strongest associated gene variants in European patients was identified to be IL-13, which we know, of course, plays a crucial role in AD pathogenesis. We did a Mendelian randomization study a couple years ago, and this has been replicated in other data sets as well, showing a link between AD and AA. And as you can see here, one of the genetic variants that drove this association was IL-13. Again, it's a very recognizable gene. So again, I'm not going to go through every single study here, but you can see a trend where AD patients are significantly more likely to develop alopecia areata than patients without AD. Whether it's in Taiwan here, this is a female US registered nurse study, a meta-analysis combining various studies. In Denmark, in this one, AD was over 26 times more likely to develop alopecia areata. Again, whether we look at retrospective, database studies, the trend is really clear-cut here. In this case, of 200 patients at the Cleveland Clinic in the early to mid, or the last couple decades, 45% of people with AD, with alopecia areata also had atopic disease. Again, can spend the next 15 minutes just going through study by study. AD is a risk factor. So this was actually that Taiwanese study that I mentioned. We can see very clearly here that if you have AD, over time, your likelihood of getting diagnosed with alopecia areata gets increasingly elevated. And in this study, it was a 6-fold risk of developing alopecia areata. In this study, they actually identified a bidirectional link. So alopecia areata patients were also more likely to develop AD, and we can see here, again, approaching that 6-fold range. There's another study here in the UK, again, different populations, where we see a pretty similar pattern, where people with alopecia areata increase risk for AD. AD is not the only atopic disease that's elevated in patients with alopecia areata. This was a study in Japan. We can see by far the most common 3 comorbidities were atopic dermatitis, asthma, and allergic rhinitis. And this association is particularly evident when we look at the severe alopecia areata subtypes, alopecia totalis and universalis. Again, very, very much highlighting this link in many patients with atopic background. Alopecia areata flares are also seasonal. So this was one study looking at over 300 children and when the disease flared, and we can see that kind of bimodal increase around the times where allergies are more significant. And there's even a hint of that occurring in individuals without clear-cut atopic clinical disease, suggesting that, potentially, and this is an area that requires more investigation, that maybe even in people without overt atopic disease, there may be a role for some of this type 2 inflammatory inputs. Looked at a large database study in the US here, looking at seasonal allergies and food allergies as potential risk factors for alopecia areata as well. And those with an allergy were almost 1.5 times more likely to develop alopecia areata, 1.7 times more likely to develop severe alopecia areata, and individuals with both food and seasonal allergies were essentially twice as likely to develop alopecia areata. This is a different database in the US where we looked at other allergic diseases. You can see asthma, allergic conjunctivitis, and so on. But I think interestingly here that the odds of having or developing, or in this case having alopecia areata, increases with the number of different atopic diseases. So we see a little increase from 1 to 2, and then a big increase in the odds ratio of having alopecia areata with 3 or more allergic conditions. This was a study done a couple years ago in Israel with 50,000 patients. Again, increased odds of having different allergic diseases, and we see here exactly that same pattern. So increased odds of any atopic comorbidity, a little increase beyond that if you have 2, and then a big jump with 3. So the more atopic, the more likelihood of developing alopecia areata. And again, it's not just the odds of developing alopecia areata, but this was a study in Europe that looked at the age of onset. And so alopecia areata only mean age of about 30, and then increasingly with more atopic comorbidities, that age decreases. And so with 3, onset as 20. And we actually see below that with non-atopic, immune diseases that we don't really see the same pattern. So atopic disease is a risk factor for developing alopecia areata and also earlier. Alopecia areata is also a risk factor in the offspring of mothers with alopecia areata. So we see here increased risk of that, but interestingly, mothers with alopecia areata also have increased risk of offspring with AD, allergic rhinitis, and asthma as well. So in summary, there's a wealth of epidemiologic data here from around the world that really shows, number one, that this is a very common disease. Again, that estimate about 2%. Peak onset 20 to 30 years, and hopefully it's evident that there's a very strong link with atopic disease broadly and atopic dermatitis in particular. So thank you very much. And with that said, hopefully our slides are ready for Dr. Gutman. So maybe we can load the slides. So my pleasure to introduce Dr. Gutman, who does not really need any introduction, but we'll do so anyway. So the System Chair of Dermatology and Wellman Professor of Dermatology and Immunology at the Icahn School of Medicine at Mount Sinai, Director of the Center of Excellence in Eczema, the Laboratory for Inflammatory Skin Diseases. Her major focus has been atopic dermatitis and alopecia areata, so quite relevant here. Among other notable achievements, Dr. Gutman co-founded the International Eczema Council, was previously the past president, speaks as the keynote and plenary speaker in international meetings, has hundreds of peer-reviewed publications, and could spend the next 10 minutes listing accolades, but we'll end there, and I'll pass the mic to Dr. Gutman.
So much, and for those of you that do not know, I got into the alopecia areata field a little bit through the back door, as I'll explain to you. It wasn't my primary field of research, but now I'm very passionate actually about alopecia areata research. There is nothing more satisfying than seeing a patient with no hair, growing hair, and it became now one of my major fields of focuses. My disclosures, but nothing related to today's talk. So atopic dermatitis is now a disease that has tremendous translational revolution, right? Maybe more than psoriasis, that has so many drugs that went into it, but atopic dermatitis is now an amazing success story. And the reason being was studies in human. I'm a great supporter of human studies because many times mouse studies will not give you the exact phenotype of patients. And in fact, sometimes they will point you to the wrong direction. And I think that's what happened in alopecia areata. So how did we get to this amazingly successful point we now are at atopic dermatitis? Through studies, bench studies of pathogenesis, translational studies done with human samples that really allowed us to propose what are the mechanisms of the disease and maybe propose a molecular map for atopic dermatitis. And I think my group was instrumental in these studies. And that led to clinical trials with many targeted agents that also fortunately included biomarkers, and we were fortunate enough to participate in that therapeutic development. And that led to not only identifying biomarkers of therapeutic response, but let us understand what are the immune pathways and what are the molecules that are important for the disease. And like everything in life, not only successes, but also the failures were really important to frame the directions and the concept. And I want to remind everybody about the flap in psoriasis of targeting Th1 in psoriasis, right? Psoriasis was considered a long time ago, very similar to alopecia areata, a Th1 only driven disease, right? But then targeting Th1 in psoriasis with an anti-interferon gamma completely failed. And that's why, again, it's very important to do studies in human and also not accept dogmas as they are, right? When we started, alopecia areata was considered a Th1 only driven disease. And I can tell you that it was very hard for me, and Natasha knows this, to publish my first publications, but now I think this is accepted widely. That's why Nature asked us to write the review. So if you believe in something, you need to go for it, no matter what hardship you will face in the beginning. So with that, can the translational revolution in atopic dermatitis also translate to alopecia areata? So I will tell you that the answer is yes. The diseases are similar. There are also, of course, differences that we need to be aware of, very similar to atopic dermatitis and asthma. Alopecia areata is also highly prevalent, about 2% a lifetime prevalence. Usually affects the scalp, but can affect any body area, and up to 20% of patients, between 10 to 20%, will have alopecia universalis or totalis. And I don't need to tell you how much of an emotional distress it causes to the patient, but also beyond the patient, to the entire family. Therapies are still limited, even though we made big strides in alopecia areata, but still we have limitations in these treatments. Let's not forget pregnant women, patients with different comorbidities sometimes or immune suppression that cannot take JAK inhibitors. So we still have many, many limitations for our patients. But we made big strides because originally the treatments were only intralesional steroids, DPCP that is extremely messy, irritating, patients hate it. I never give it to patients. And other therapies that are either immune suppressants or simply not working, and do not give systemic steroids to patients with alopecia because it's worse than a Band-Aid. The moment you stop, they will shed all the hair. So it's worse than a temporary fix. So definitely do not do that. So we still have a very large unmet need for safe and effective treatments for alopecia areata. An important consideration also that very similar to atopic dermatitis, alopecia areata is highly heterogeneous, right? We know that atopic dermatitis is very heterogeneous, unlike psoriasis that is really homogeneous and focused on IL-17, IL-23. That seems not to be the case in alopecia areata. There are many clinical presentations, and we now know that these presentations may be associated also with differences in the immune abnormalities of patients. For example, atopy, you heard from Benji, patients with a concomitant atopy will have a strong Th2 background. Now, it doesn't mean that the other patients don't have Th2 skewing, but the Th2 skewing is much, much stronger in those patients that have atopy. Now, we are very fortunate because now we have many treatments going into alopecia areata. Of course, we have the oral medications, including the JAK inhibitors. We now have 3 JAK inhibitors approved in the United States, and in most parts of the world, 2 JAK inhibitors approved. And there are also differences. I just came back from a meeting in Israel, and in Israel, for example, ritlecitinib, you can prescribe for patients that have only 20% scalp involvement or more, which I thought is so important because those patients that have 20% scalp involvement, right, they suffer also. You don't need to have 50% scalp involvement to be entitled for a systemic. So I thought that this is something that we need to push also in the United States and other parts of the world. We now have several biologics going into atopic dermatitis, including our study that you'll hear a little bit from some patients that actually are in the study or finish the study, our study with dupilumab, and some other studies with biologics that you'll also hear at the ISDS meeting, some new data about some of these studies like AX40 antagonist going into alopecia areata, and some others. Very, very exciting times for alopecia areata. So important for you to know that JAK inhibitors are working well, but they are not the only game in town. We still need additional treatments that will be targeted for patients with alopecia areata. And I'll not talk about it today. I'll talk about it during my talk on Friday. But alopecia areata, like Benji hinted, is not only Th1 driven. We showed that it has involvement of multiple immune pathways. So of course it has Th1 involvement, but by the way, the Th1 axis is also involved in atopic dermatitis and in psoriasis. And in alopecia areata, we associated the Th1 axis with the chronicity of the disease. So the more chronic the disease, the longer you have the disease, you'll have a stronger Th1 activation. We associated the Th2 pathway actually with the severity of alopecia. So the higher the SALT, the higher the Th2 immune activation. And there is also involvement of IL-9 and IL-23 in patients with alopecia areata. So again, the Th1 is not the only game in town. We never did this exercise, but I want to remind you that in psoriasis, targeting Th1 alone, interferon gamma alone, failed in psoriasis. Now, JAK inhibitors have a plus in alopecia areata because they can target multiple immune pathways, and I just told you that patients with alopecia areata have involvement of several immune pathways. Among these, the Th2, Th1, IL-23 cytokine, and also IL-9. And I want to briefly walk you through our mechanistic study with ritlecitinib. So ritlecitinib, or Litfulo, targets a JAK3. Because it targets the JAK3, it will target gamma-C cytokines, among which are several that are Th2 cytokines like IL-4 and IL-7. And this is the clinical data, and it was very significant. For those of you interested in clinical trials in alopecia areata, the placebo responses are very low, unlike the placebo responses in atopic dermatitis. Very attractive disease in terms of doing a small study. You don't need large studies because of the small placebo response, and you'll get a very clear-cut result. And in terms of mechanistic data, we showed that what are the pathways that are improving in our patients. So Th1 significantly improves, but also the Th2 pathway significantly improves in patients, and also IL-12/23 related markers, and hair keratins that are very important biomarkers in alopecia areata are going up, right? And importantly, they went up way before the clinical results happened. Because in alopecia areata, we know studies take time, but when you do biomarkers, you'll see the results much earlier, and many companies are actually using these biomarkers, as you'll see in the AX40 study that I will present tomorrow. It's a good way to get you a hint of efficacy if you cannot do a very long study. Now, importantly, I told you that Th2 is important, and you don't need to believe me, but let's review some of the correlations with changes in clinical severity. So these are the data from the ritlecitinib study, and let's review what biomarkers correlated with the improvement in SALT, or with the hair regrowth. And when we look carefully, we see both at week 12, so very early. You already see CCL17, right? This is the key Th2 chemokine, is front and center. And when you look at week 24, look again, CCL17 and IL-13, these are very important with very strong correlations between reductions in these biomarkers that correlated with the changes in disease severity. And what got me interested in alopecia areata is actually this patient and another patient. So we were doing dupilumab studies for atopic dermatitis at Mount Sinai in 2013. We are actually the largest enroller, and because of that, we had many patients at our site, among which this African-American patient and another patient. And I started to notice that they had also alopecia areata, and they actually grew hair with dupilumab. So that was very strange to me, because at the time, the dogma was that alopecia areata is only a Th1-driven disease. But I'm also a physician scientist, and I questioned it. And then I started to look at the literature, and I saw that there was a huge bulk of epidemiological data showing that atopic dermatitis and in general atopy, including asthma and other atopic comorbidities, are actually the #1 comorbidity of alopecia areata, about 40%, way more than thyroid, right? All of us as clinicians, we ask patients about thyroid. But atopy, you should ask first of all about atopy because that's the #1 comorbidity. And then I saw that there was a lot of data on high IgE or specific IgEs, like Natasha talks in her lecture about different IgEs, not only the high IgE that are actually meaningful in patients. And then I also saw that for many years, Wilma Bergfeld and others were giving antihistamines to patients with alopecia areata, but not questioning why. So we always need to question why. So the reason being is that atopy is important in these patients with alopecia areata. Now, antihistamines will not grow most of the hair by itself, but it will act as an adjuvant, very similar to minoxidil. So this is the study that I told you that was done at Harvard with more than 2,500 patients linking atopy to alopecia areata, and the study that Benji already talked about. And I also want to say that the largest GWAS study done in the United States linked IL-13 as the primary association with alopecia areata, both in patients with atopy and without atopy. They did not see a difference between these patients. And this is the association between alopecia areata and the seasonality, like Benji talked about, and flares, right? Flares are always associated with seasonality. And I think it's now quite accepted that there is that correlation between atopy and alopecia areata. Another evidence comes from dermatopathology. In the dermatopathology literature, we see eosinophils and mast cells, and we are showing that too around the hair follicles, actually in majority of patients. Of course, more in patients that have associated atopy. And that led to our first study with dupilumab. At that time, we did not know that we will find better responses in those patients with either atopy or high IgE, but at least we thought about that. So we enrolled enough patients that had atopy, but only 6 of the 60 patients actually had active AD. But many of them had history of AD or family history of AD, and all of this matters. And we found that those patients that had either personal or family history of atopy and or high IgE are the ones that responded. Now we are doing a continuation study, but we are focusing more on personal atopy and a high IgE. And these are some results from the original study, and all of these patients are still treated with dupilumab. All of them now have full hair. So it took some time. I always like to say that dupilumab is a marathon runner for alopecia areata. Unlike in AD, it takes much longer. In general, for a biologic, it will take much longer than for a JAK inhibitor. Do not expect with a biologic to have the same results at 24 weeks like you have with a JAK. That's not going to happen. But patients will tolerate it because you also don't pay the same price, right? You can conceive on dupilumab, you cannot conceive on a JAK inhibitor, and many, many other issues. This is a patient from our current study, and I will never put in my lecture pictures of a patient from a study, but this patient posted it herself on Instagram, and you can find her also on the Mount Sinai Instagram. So this patient had alopecia universalis, and she's also very vocal about her disease. Had alopecia universalis for about 3 years. Participated in some studies, did not grow hair, and we enrolled her in our dupilumab study with weekly dupilumab for adults. And now, by the way, you can look at her Instagram. She has actually long hair. But this was after she graduated from the study at 48 weeks. She grew all her hair by now. And we also published a large case series in children, about 20 children, showing a regrowth in about 70% of the children. That was in real life, so it was between 6 months to 18 months. But we are doing an NIH study that is doing very well with enrollment, and we have some of the children in the study that will actually be speaking to you today, and many of them are growing hair, and we are very excited about the study, and Natasha is also a part of our study as well. And this is a child that was not part of the study, but is my patient at Sinai. And this child was 6 years old when she came to see me, and she was on tofacitinib, 5 milligrams twice a day. I did not know who would put such a child on tofacitinib. Tofacitinib is a drug that I want to remind you did not get approval for psoriasis. It had 2 patients that actually died in the psoriasis study. So I do not think that's a good drug to put a child on a drug that is not available, and particularly for children. In any event, tofacitinib did not grow her hair. However, dupilumab did grow her hair, and now she has full regrowth. It took some time. The middle picture was after 12 months. So she still has SAL20 after 12 months, but after about something like 16 to 18 months, she grew all her hair, and she still has her hair to date. So to conclude, alopecia areata is a highly inflammatory disease, very similar to atopic dermatitis, with an emerging role of Th2 in addition to Th1 cytokines. And I think evidence is already there that alopecia areata is joining that atopic march or type 2 spectrum. And even in the allergy world, it's now accepted. And I think increasing understanding of alopecia areata pathomechanisms and keeping an open mind in general is key to promoting new treatment approaches. With that, thank you so much, and I want to thank so many people at Sinai that are part of our journey in alopecia areata. We really want to make a difference in patients' lives. Thank you so much. Now I want to invite really the queen of alopecia areata that I consider a very dear friend, Natasha Mesinkovska. She really made so much difference in alopecia areata and is speaking all over the world. I'm always in awe of her. I always see online that she is speaking somewhere, but let's hear from the queen.
That's what friends are for. See, we all need somebody to cheer for us. They gave me a very big title for today, so I'm like, I have to be important. I changed my font. I changed everything I could. When you load up the talk, let me know. It's the one right on the top in the middle of the screen with the little yellow square. There we go. I know your desktop better than you. There we go. Okay. See, when I said they gave me a really big title, I wasn't kidding. And I did read a lot more than I should, and then I went back to basics anyways. I just decided I'm going to tell you what I know. I always say my whole life is a conflict of interest whenever I give alopecia areata talk. I cannot exchange a pair of shoes that are too big for me, but I can fight for patients as much as I can my whole life. Why are we here, and why are we talking about atopic dermatitis and alopecia areata? Well, you got to see the slides from both of the prior excellent, eminent speakers. But bottom line is atopic dermatitis does have an association with autoimmune conditions as these patients kind of get adults. I always feel like people start out hot, and there is a point in life to which they turn into this like sensitivity that goes to autoimmune conditions. And how is it and when does it happen, I think is one of the stories that kind of connects atopic dermatitis and alopecia areata. So these are things that I put up here. Why? Because it pertains to most of the people in this room. So what I didn't know is that more women with eczema are actually prone to autoimmune conditions, whether that's a reflection of just women overall being prone to autoimmune condition, but this is something we definitely see here. But one thing that we have to keep in mind when it comes to atopic dermatitis, and why should we even treat it, right? Why should we step away from that cream is because it does have a modest, albeit, but there is an increased risk of mortality. 2 of the biggest studies actually show it. The severity is the one that's associated with it, and asthma always. Usually it's infections and a couple of cancers that are there. When it comes to alopecia areata, atopic dermatitis is the most common comorbidity. And even a recent one study, I think we still underestimate depression and anxiety. When we ask patients, like the study did in Finland in a survey, they tend to identify it. But through our modalities, through all the very complicated psychosocial measures, we usually do not. But one thing I would say is, should we treat alopecia areata? And why? Because there hasn't been a signal of increased mortality. If anything, it may be protective. These are big studies that were done that are showing not just random cancers, but colorectal cancer that right now is wiping out people in their 30s and 40s, right? We did a study to TriNet X. These numbers were too good to be true, but we did everything that the Koreans did in their vitiligo study, and it did show the alopecia areata people had better survival compared to matched healthy controls. So should we treat alopecia areata? If the atopic dermatitis increases mortality, but alopecia areata does not, what are the people that have both? Where do they fall, and what should we do? So to treat or not to treat? And I'm not trying to be like super, esoteric here, but I did hear one of the best talks of my life this summer at the EADV. And this was a talk that was done by Dr. Griffiths from UK, and it said, should we and can we cure psoriasis? And I'm like, darn, the first day I joined the National Alopecia Areata Foundation, that's what the goal was. It was cure, that's what patients wanted. And I was like, what do you define cure? And his explanation, the way he said it is, we think about inflammatory disease the way we talk about cancers. You cure cancers when you don't have to treat it for 5 years and it's staying away. And I'm like, okay, but it made sense, right? It made sense. The whole thing of the whole talk was really to treat early, because the way he described it in the psoriasis inflammatory milieu, but it really is any chronic condition we deal with, is that things start out in a certain T cell pathway, but then they really differentiate themselves and become that kind of T-reg regulated, not regulated APC stuff that we need to address. So is it possible that all these chronic inflammatory conditions that we're trying to attack are just at different stages, right? Easy to blow things where early on, but it's much harder to get rid of them when they're there. And this is a message we're getting across from atopic dermatitis too, and from alopecia areata. There are studies now, and the pediatric dermatologists are really pushing for this. Should you give a lot of creams to infants if there's a family history of severe eczema, or should you try to treat with systemics early on so you prevent the food allergies, you prevent the asthma from developing? Should you use pruritus as a marker and not the surface area? So these are some of the things that are being brought up more and more with our pediatric derms. And then from the alopecia areata world, we see this internationally. The US studies, European studies, and the latest one from Japan. Duration of the alopecia areata episode will predict how effective your treatment is. And there's this whole thing about the 4 years. Japan study showed it too. What is it? What happens about that 3.5 to 4 years? Is there a CD4, CD8 conversation that just completely goes to CD8? I don't know. But these are some of the things that we have to do. But before we even talking about, are we treating early? Are we treating late? This is what one of the latest surveys showed from alopecia areata patients. In the US, tends to be maybe a little bit lower, but this is the number of people that still don't go to the doctors to ask for medication. So I feel a lot of the companies and a lot of people that are making medications, they're like, but where are the patients? Why is my medication not being prescribed? People are still sitting at home. They're still not coming through, most of them because they were so disappointed from things, or most of them because of all these dogmas of why are things caused and where are things going. So the dogma, like Dr. Gottman said, was that really allergy and alopecia areata, completely different parts of the spectrum. You have to worry about autoimmune versus inflammatory, but that's all being just gone and wiped out. The latest and best paper that I found on this topic, and the one that I'm gonna definitely show you all the figures from because it did a very good thing, was this. These are the pathways that we taught. Atopic dermatitis on the one side versus alopecia areata on the other. Th2 versus Th1 responses, but the reality is that they do overlap, and they overlap very nicely. The Th2 stuff is what we found that is that CD4 definitely overweight CD8 T cells. And in addition to the Mount Sinai papers, Dr. Gottman's paper, one of the latest papers that I really enjoyed on this topic was Dr. Ali Jabari. Ali trained in Columbia, so he was definitely this is not connected to atopic dermatitis, has nothing to do with CD4, did a brilliantly beautiful study, and I think everybody should read it, where he showed that actually CD4 cells are very, very important in addition to CD8, and they may have a role to prime. So at the beginning of things, this is what it does. So I'm gonna just mention or discuss very briefly what are the treatments where these things overlap. And I'm gonna call them IL-13s and friends, the JAK success, because it really is a marvelous success story, OX40s, and we're gonna talk about the Tregs. So preventing the atopic march. I definitely know that in my, well, no, nothing is definite, but I think it's important when you do research and we all kind of bounce out of it in our mid-career, it's still important to see patients. You have to have your finger on the pulse of what's going on there. Because the only way I can know is that when my eczema patient, when their eczema on the hands flare, I'm like, you better put the triamcinolone, we better get you on something systemic, get the antihistamines, because the spots on your head are gonna come in 3, 4, 5 weeks. It's a thing. It is part of the atopic march, and that's how we should treat it. So IL-13 pathway inhibitions, you got to see some of the stuff, but this is just to kind of show you the involvement from skin barrier dysfunction to inflammation to itch. So that's why these things have really revolutionized the way we look at atopy. We did not think they're part of alopecia areata until this beautiful figure here that was probably made here at Mount Sinai, but just to show that some of these medications that address these pathways can actually affect alopecia areata development and thus treatment. In addition to the antihistamines that we all prescribe for a very long time, the role of dupilumab in alopecia areata is there. And people will always be like, do you really think it works? Are you sure it works? It does. It works slowly, but it's not for everyone. You have to find the right patient. I still do IgE, but for me, I think it's mostly the younger kids, the ones with atopic dermatitis, so that whole thing, catch early and get history and get a sense. This is a kid who we tried to get other things, we couldn't, and this is him regrowing after a year or so minoxidil, we couldn't get much on dupilumab. This is a case report on another IL-13 targeting therapeutic, and this is tralokinumab in a 33-year-old who had atopic dermatitis, and you can see the back of the head. Now, the back of the head is that ophiasis pattern. It's a very difficult to treat pattern, so it's pretty much miraculous that he even regrew. But just to show you these medications and why are they important. Everybody always will say, well, wait a minute. Dupilumab has been associated with alopecia areata. And we know this from anyone that treats a chronic inflammatory condition knows. You treat inflammatory bowel disease with a psoriasis biologic, you get psoriasis. So it's things that we have seen before. But there is an alopecia areata national study done. They called it national, but it's really a TriNet X. The fault with TriNet X, which is a large database, and there's a huge trend of everybody publishing with it, is that you can see when somebody prescribed the medication, but you can't tell if somebody picked it up or refilled it. So I think it's still not there. Bottom line is they used a very high number of very nicely matched controls. They found 105 cases of alopecia areata on dupilumab patients versus 74 on controls. And you can be like, amongst the 20-some thousand, it doesn't look to be a big difference, but they did say actually it is a big difference. They went on to say that maybe we're underestimating things, but one thing that sticks out when they pile up stuff and pile up all the literature cases that were reported, the youngest one ever is 26. So even in their database, they found no children where this was documented. So this is something to keep in mind. Why? Because I think the children are the ones that actually have that alopecia areata and atopic derm. So dupilumab will be even more relevant for them, but also very encouraging as a physician for me to know that if I give them dupilumab, maybe they're not the ones that are going to develop this. Just so you know, if you try to look at drug-induced alopecia areata or a flare, there's tons. So this is just from the first page of PubMed. There's IL-17s, there's even JAK inhibitors associated with flares. So no drug will be spared, and some more I will mention. So before I leave my IL-13s, why do I like them? There's no labs. Yes, there is a poke. They're still best for children for long-term stuff and for people that have immunosuppression or clots. And right now we do. I have people with melanoma, people with breast cancer, people with stuff that want to be treated and I don't know what to do. So this is probably the way to go because JAK inhibitors may not be there. But let's talk about the JAK inhibitors because this is a story that is like none. I had a very prominent biologics derm come to me. They're like, why would you give people JAK inhibitors? They have such strong side effects and you put them at risk for cancers. I'm like, well, first a pill. Second, it has a very, very short half-life, like most of them do. So it's kind of very easy, and they work. So for all these years, for a decade now, I do trials with all of them in alopecia areata, many in atopic dermatitis, psoriasis, so I've gotten comfortable. But why are these pathways important? As we're becoming to know more and more personalized medicine, there's actually atopic dermatitis now, gain of function or even loss of function, things with JAK-STAT pathways. So JAK1, there I found 27 cases just to show you some of the latest trends. So when a kid comes with severe eczema, you know what they're going to develop or what to check for and things to do, and some of the genetic mutations because now they're very easily accessible. So this was a very cool case with this kid had this mutation. They tested both pairs. The dad had this gain of function mutation. But the cool thing is that they treat him with upadacitinib, and what happened is the kid had TSH abnormal and thyroid antibodies, and the thyroid antibodies went down. Then when they checked his inflammatory markers, they're honestly associated with all sorts of conditions. They put both him and dad on JAK inhibitor. Both of their markers for autoimmune diseases went down. So to tell you that with some of these medications, you modulate not just the alopecia areata, and we've seen them with rilicitinib in people with celiac disease. So if anything, JAK inhibitors were primarily used for atopic dermatitis, and they showed superiority to some of the IL-13s, but people are scared. Upadacitinib is a great drug for that. It's probably going to be one of the better drugs out there for alopecia areata 2 as the phase 3 trial data is coming out. So let's transfer to alopecia areata. They work beautiful. They really do. When used correctly, they work in a certain percent of patients, though not in everybody. These are the 3 that are approved. This is the medications that the way they look. So you know what you can cut, what you cannot. The only one that's given twice a day is duroxylitinib. When you look at how they work and how fast they work, duroxylitinib may have a leg up, so that's their claim to fame currently, but at 36 weeks and later, they all tend to even out. But if you see these numbers for medications that grow most of the hair are not a 75, they're not at 80%. My point is we still have a room for more. So why are they not prescribed? Why are patients not coming across, and why are my colleagues scared of them? Because of this box warning. We dermatologists are used to the infections and the malignancies. We're not used to the cardiac events and the thromboses. When you look at a patient, for example, baricitinib data, rilicitinib data looks the same. Day-to-day, very well tolerated, maybe a headache in a low percent of patients. Infections, opportunistics are not, we don't see the stuff we see with the biologics. Herpes zoster comes up. A recent meta-analysis showed that herpes simplex actually does not. But when you compare atopic derm versus AA, they may have a little bit of more herpes simplex than AA. But zoster for sure, but not much else. When it comes to cardiovascular risk, I have had an event on one of the medications, so I'm very, very scared of it. Data right now actually may show that some of the inflammatory markers may even improve, but stay tuned for that. Everybody will tell you that the box warning is from tofacitinib in rheumatoid arthritis patients. We just did a quick TriNet-X that I tell you of tofacitinib patients, rheumatoid arthritis versus AA. All of the things were still present in the alopecia areata patients, but definitely rheumatoid arthritis patients were sicker. They had more infectious, particularly lower GU, and then the thromboembolism was more significant in those patient populations than alopecia areata. Looking at the serious adverse reactions, this is the baricitinib data. I always can still feel comfortable, and I always probably am annoying for people that hear me saying this, but I can still count the number of malignancies and serious stuff on one hand after all these years, after thousands of people being on there. So this is something that at least I can tell my patients. Why? Because this is not something we're going to give you. You're going to grow your hair, and then you're going to stop it. This is something that we should go on, at least for the stuff the way we know it now, for a long time. When can we take you off of things? If we start early, or if we figure out new medications to continue this past the point of stopping. What happens when you stop the hair? This is the proper slide. This is my slide. 80% of patients will lose their response. Doesn't mean they're going to go bald. If you want to be the cup is full, which is very foreign to my pseudo-Eastern European roots, 20% of patients will keep their response, but we still don't know who they are. We think it may have to be with duration of episode, but we still are not 100%. These are the people that are left out. These are the people that come to my door. And these are the people, I have 2 patients that have gotten clearance from their hematologist for me to put them on a JAK inhibitor, back on a JAK inhibitor after having clots. So these are things that will come through our doors and things that we'll have to think about. So when those things don't work out, what is next and where is the next exciting stuff? So OX40 signaling, this is the TNF receptor superfamily. They're co-stimulatory for T cells. We learned the lessons from atopic dermatitis, and now we're borrowing them in alopecia areata, and hopefully they will help us out a little bit more in patients that have both of these things. OX40 pathways are very important for T cell expansion and survival of effector memory T cells. So the whole goal is if you intervene, you can control inflammation, and you can have a little bit of the sustained response to T cell control. So these are the medications that you can see for atopic dermatitis. Some of the evidence is there for the EASI score reduction. Amlitelimab is tried in alopecia areata right now, but we don't have the data yet. And IMG 007, I think there's going to be posters at this meeting, oral presentations on more details of the data. So I'm excited to hear it from the authors themselves. This is cool stuff because it's a little bit of a different way to approach things. So IL-2 receptor pathway agonist with a Treg rescue. This is kind of, instead of pushing things from one to another, you're trying to rebalance and establish an immune system by increasing the Treg population. There's investigational uses for alopecia areata and atopic dermatitis. And you can see some of the data that's come up on atopic dermatitis. It definitely shows the medication does work with sustained durability 36 weeks after treatment. So this is exciting stuff. Safety has been super excited with no significant lab abnormalities. Alopecia areata, we still don't know, but we hope it will work. This is the name of the game. All right, therapeutic venues. I was looking at all the new cool things that are coming from Aslan Pharmaceuticals for everything, but I really couldn't come up with anything that is kind of overlapping. Interesting thing was for nemolizumab. So IL-31, cool thing to have for your itchy patients. Prurigo nodularis, not much work. Dupilumab, we were hoping it would work, but this IL-31 receptor agonist is interestingly present in the outer root sheet of keratinocytes, and it's also found in inflammatory infiltrates around cells. So can this be used for the hair? And that has been a thing because elevated levels of IL-31 have been found in scalp and in blood of patients with alopecia areata. And it's interesting because it's been found in lesions that have been associated with itching. When you think alopecia areata, they're not the itchy patients, right? Like that spot doesn't itch, but IL-31 is with those. So can you block it? Does NEMO have a role? So far, nothing. I think somebody must be working on this. The only thing I found is what you find with every medication, that is that one patient did develop alopecia areata when they were treating his atopic dermatitis and pruritus, and they stopped the medication, and within 6 weeks, he regrew the hair back. Last but not least, just to introduce the technology of these pegylated peptides. These are hand-picked multi-cytokine inhibitors where you can kind of pick and choose what you put and what you want to block. We have it for alopecia areata, and it's going to be hopefully made for atopic dermatitis and many other conditions. This is the way it works. If monoclonal antibody is in the first row, JAK inhibitors block the 50 so cytokines, these peptides. You're like, I want 2, I want this, I want that. So according to the pathways, IL-2, 9, and 15 is the first one that's out there. This is how it's going to work. It's going to control the CD8 and a little bit of the mast cell. So you have double stuff that's happening. The phase 2 adult stuff, I don't have anything recent or anything new, but we know that it does work, and they're trying to work on a model that goes from IV to sub-Q. Last but not least, when they did the alopecia areata survey in the Scandinavian country, particularly in Finland, where people love their saunas, love their vodkas, and they're outdoors, what do you think their most common source for information was? It was not us. It was social media and peer support. So I always tell my residents, you don't have to be an influencer, but you need to get out there and educate. But this is a message that I want to give to everybody in this room, from a PhD to an MD. Thank you so much for your attention.
So now I want to introduce, but he doesn't actually need any introduction, Alan Irvine, that is also the president of the IEC. He is one of the most known people working in the atopic dermatitis space in general, and pediatric atopic dermatitis in particular. And he also published on alopecia areata, and he'll speak actually at this meeting on atopic dermatitis. So I don't think he needs a lot of introduction. He comes from Ireland, from Dublin, published hundreds of publications, was featured as keynote speaker in many meetings, got many international awards, and published really many highly impactful papers, primarily characterizing the skin barrier of atopic dermatitis and mechanisms of atopic dermatitis. And now he will talk about systemic therapies for alopecia areata in children, what's being used now, what's coming down the pipe, and what have we learned from atopic dermatitis. So, Alan?
You might I was tasked with talking about comparing and contrasting the journeys to treatments in children. And so by children, it's 12 and under, really 12 and up, to 12 to 17, classically in trials, we think as being as adolescents. Now, just got to dichotomize in some way. There are no approved therapies, systemic therapies for alopecia areata in young people under 12 years of age. So that's just an important thing. So everything I'm going to talk about today is off-label and off-license, and occasionally you'll see some caution labels just to say that that's what we're talking about. So those are my conflicts. So we do have to talk a little bit about eczema today because it's partly the IEC. But one thing I just wanted to talk about was the journey that we've been on atopic dermatitis, and to see that maybe as a journey of hope, and maybe some learnings from that, how we can get to better treatments quicker in alopecia areata. So the first thing I wanted to share was something that's just over a decade old, and this is what the world looked like in 2013 in Europe for severe atopic dermatitis. Remember, there were no approved therapies in 12 and under at that point either. Cyclosporin's approved for 16 and over. So in this one, you looked at 340 dermatologists at that point who were treating kids. Oh, whoops. This is the pointer here. Who were treating people for severe atopic dermatitis, and everything here was off-label: cyclosporin, corticosteroids, azathioprine. Corticosteroids was the first and the second, most common medicine. So if there's another first line, cyclosporin was the second, and methotrexate was the third. So this was the way things looked if you got severe atopic dermatitis just over 10 years ago. A lot of off-label choices, a restriction on them to people who were really dealing with severe disease rather than moderate to severe disease. And then we can look and see just where that journey has gone. So we started off in the 1950s with methotrexate, in the 70s with repurposed immune suppressants for transplant patients, cyclosporin. Then we got some broad immune suppressants topically, like tacrolimus, and slowly we developed into a more targeted cytokine-driven disease treatment offering. So the symbols here, just there's FDA and EMA approvals. These are 5 to 11-year-olds, and these are younger kids under 6. So just we take a little look at these and where we got dupilumab approved in 2017, tralokinumab a little later, nemolizumab in Japan a bit earlier, and now more widely, lebrikizumab later again. But if we look at dupilumab, there's a big delay between 2017 and 2020 when we got it into 6 to 11-year-olds, and then another delay again to 2023, like a 6-year delay before we were treating really young kids, 6 months to 6 years with atopic dermatitis. And that's a lot of people who've missed out on opportunities for treatment. And we heard earlier from Natasha that early treatment, we believe, in alopecia areata gives you better results. So it's a challenge in under 12s as to know what to do and what treatments to offer kids and their parents who are very distressed by hair loss. Small molecules, the same kind of thing that we see with the small molecules that we've got in, topical agents and systemic agents. We've got Delgo. I haven't put the most recent approvals for Delgo in here, but now widely approved in America and the States for chronic hand eczema. And we've got some PD4 inhibitors as well. We now have then, if we just click on here, baricitinib approved down to 2 years of age in Europe, and we have roflumilast approved topically down to very young ages as well. So we're seeing some of the small molecules and the topicals particularly getting to approval relatively quickly, but baricitinib, there was quite a delay. The baricitinib was only 3 years of delay getting to approval. So what's the landscape like here? If we were to repeat the exercise from 2013 in atopic dermatitis, where lots of kind of things were being used, this is a more recent kind of expert opinion. It's 5 years old, therefore out of date, but it gives you a sense of what was being recommended by experts at that point. You know, corticosteroids, we really want to avoid corticosteroids generally in almost every inflammatory mediated disease, but they still were widely used 5 years ago and recommended. Calcineurin inhibitors, not especially helpful, really, but they're recommended. Prostaglandins for eyelashes and eyebrows. Minoxidil, we're going to talk a bit about that, and dithronol, and then diphencyprine, which really is a kind of horrible drug if you've used it. All your nurses eventually end up contact sensitized to it. But that's only 5 years ago when what was the best things available. And Natasha's covered how the JAKs have transformed things to some degree. If we look at pediatric specifically, we'll see dithronol still being used, contact immunotherapy, multiple reports, minoxidil, cryotherapy, which seems kind of crazy, but there you go. Some people were using it. Intralesional corticosteroids. Emma's talked about how unsatisfactory an experience that is for many people, and prostaglandins. This is what was out there and what's available and what remains available on license, off license under 12 years of age. I wanted to give you another sense of just what patients are experiencing and being offered in a more kind of global thing. This is GRAS, which is a registry, a living registry. At the moment, it's in Italy, Ireland, and Australia, and many other countries are expressing an interest in involving. And the latest data cut we have here is on 1,000 patients from all ages who are being treated for alopecia areata, and it captures their current treatments and outcomes. So I might just share this with you. This is just from a couple of days ago. These are the children who were captured in this. Again, what people are getting in real life. Large numbers on oral minoxidil. That's common in Australia, but it's common in other areas as well. Corticosteroids, topically and orally widely used. JAK inhibitors, again, these are all off-label, off-license. And traditional immune suppressants, cyclosporin, azathioprine, and methotrexate, still being used in the real world in these 3 countries, and of course more widely, but it just gives you a sense of what patient experience is like. And in many ways, it's like that 2013 atopic dermatitis lived experience, because physicians and patients don't have many other options. Let's just look briefly at minoxidil. We saw one of Natasha's patients that had minoxidil, and this is just really what I could find a week or so ago on topical minoxidil, 3 different papers including a systematic review, but really small numbers. Seems broadly safe, I have to say. You do get hair where you don't want hair, like facial hair in young women and so on is not a wanted side effect, but relatively safe. And then oral reviews as well, up to 440 patients exposed in that systematic review from last year with minoxidil. And efficacy is, of course, in a systematic review, very difficult to assess. So it's an off-label drug, but it's going in a lot. The caution sign is it's off-label. It's used orally and topically. Case reports, very low-quality evidence, you'd have to say. Under 12s, again, specialist use only. Dosing is a real problem to guess at. I think you used 1.25 milligrams. It depends on how small you can crush the tablets from 2.5. Can you get them to 0.0625? It's very imprecise medication to give, but it is quite widely used, often adjunctively. So baricitinib, again, off-label for atopic derm under 12 years of age, which is the subject of my lecture, but just by way of some reassurance, if we look in the European Union, it's licensed for moderate to severe atopic dermatitis down to 2 years of age, and there is quite good pharmacodynamic data on this. Again, the PD exposure data was published just yesterday on the BREEZE PEDS trial, and it basically are over 30 kilos. You should be on 4 milligrams, and under 30, between 10 and 30, use 2 milligrams. And that's for atopic dermatitis, and it is a license. So it's a license in this age group, but not for this specific indication in Europe. If we look at tofacitinib, I mentioned that earlier, an older, more pan-JAK. It is approved by the FDA for 2 years and up for the last 5 years. It is approved in Europe for 4 years, for 2 and up, in specific types of subtypes of arthritis. Not, again, there's a caution here, it's not approved for alopecia areata, but it does have approval in very young children. And similarly, upadacitinib is approved by the FDA, but not in Europe, so there's some regional differences. It's in consideration by Europe, and not just it's just over a year ago, and that goes down to 2 years of age. So this does not mean that it's approved for alopecia areata, but it does mean that regulatory agencies have looked at these drugs in very young children. They've looked at post-marketing surveillance requirements. They have dosing formulations, pharmacokinetics, pharmacodynamics that are suitable for very young patients. And they have formulations, including liquid formulations that are stable and are known to be reliable and have decent shelf lives. They're not mixed up in the back of a pharmacist, which so often is the experience for alopecia areata patients, trying to get things cut into tiny doses, modified to fit, all workarounds because there are no approved licensed therapies. So it's just to put that out there and to know what the regulatory framework is for these. I'm not going to talk about dupilumab other than just to show this and highlight Emma's work. And I'm going to talk a little bit about the development pipeline, but I just wanted to set out how kind of complex and frustrating and challenging and how many workarounds that we have to do in our very young children. So the development pipeline, I had a look at clinicaltrials.gov just most recently, and the pipeline doesn't require a massive table to do it for under 12-year-olds. This is Emma here. You've heard about that. And dupilumab may be particularly suitable for highly atopic and maybe suitable for younger kids, and it already has a license from 6 months up and a very comforting safety profile. So if this works out, that's going to be transformative and on label for young kids, this age group that I'm talking about specifically. And of course, there'll be access to it as well, because there will be dupilumab biosimilars coming in 2031, which will broaden the access too. Because part of the frustration, apart from the off-label nature of the drugs that I've been talking about, is just even getting access to these drugs off-label is very, very challenging too. So I think dupilumab in this age group has a chance to be a true game changer. Baricitinib I mentioned, Lilly are following that out down to 6 to 18 years, so that includes some of my age group, 6 to 12, that I'm talking about here. And Pfizer are also looking at these age groups with Ritla in the short-term and long-term follow-up studies. So we should hopefully get the approvals and the labeling down to at least 6 years, but below 6 years, it still looks a long way off because no trials are looking at those younger kids. And I do have those in my clinic quite regularly, and it's really difficult to know what conversations to have in an informed way, given the paucity of evidence. So one thing we mentioned, sorry, is a typo in this, and Natasha mentioned this about early intervention. Well, maybe this would help. These are some, Natasha also mentioned TriNetX, which is the dispensary database that we can use. And this is really looking at proxies of the atopic march for people treated with dupilumab early. And essentially, these data are real-world data. They come with caveats, but there does appear to be a signal for treating younger patients earlier. You may prevent the atopic march in some of them, or atopic comorbidities, or atopic clustering of comorbidities is probably a better term than the march. So getting in early makes a lot of sense. And you also see the similar thing with a different group using the same database and looking at non-atopic comorbidities right across the board, things like developmental delay, ADHD, really a significant delta in this real-world data, caveated with that on early treatment. So there's a strong building consensus, and Natasha's spoken to that, about getting in early. But then on the other hand, we've no approved therapies under 12. So we have this frustration of knowing that our therapies are likely to work, but the inability to use them regularly on label and in a reimbursement-friendly environment. Would the similar paradigm apply in AA? Well, I believe it would, because eventually you do exhaust hair follicles if you've long-standing AA for many, many years, and we know that the longer you have alopecia universalis or totalis, the less likely you are to get regrowth. After 5 or 7 years, it becomes a smaller and smaller percentage of people have that possibility, and perhaps that's even more so a paradigm like vitiligo, where you exhaust melanocytes, you just can't bring them back when the hair follicles are permanently gone. And it's not a scarring alopecia, but you do get to an exhaustion after a lot of immune pressure after years. Then there's maybe no way of recovering that. So getting in early is a real priority for us. So just a few thoughts on targeted development. The AD experience shows that you can get approvals down to 6 months. That's something that Leo and Lily are pursuing for Lebri and tralokinumab currently. Those trials are ongoing. I would expect that they'll read out successfully and that those approvals will be reached. So we could maybe have 2 or 3 therapies on the IL-13 axis that are approved to very young ages. So it can be done, but the timeline is really slow, and it's partly the difficulty of doing studies in very young children. Reimbursements often lag, and this is a bigger problem for alopecia areata, in my experience, than it is for atopic derm, in that in Europe, where I'm most familiar with, persuading payers, third-party payers, that alopecia areata in young people of perhaps less than 50% loss is a treatment priority, is a challenge, let's be honest. And that's where that kind of coalition of people who care about this space have to create that environment to make people more willing to understand that, particularly if you marry it with the early intervention and the potential, maybe not complete reversibility of the condition, but the ability to regrow hair and not get into an area where hair, it becomes very difficult for it to regrow. And then one of the questions that we're going to face with young children is when to stop treatment. You know, we know with the JAKs that the off effects kick in after about a year. Natasha showed you the slide with the 2 doses of baricitinib followed out over a year, and you see 10 and 20% of people still retain their improvements. So when do you stop treatment? And if you do start people on a JAK inhibitor or on dupilumab at 3 or 4 years of age, when do you feel comfortable stopping them? And that's a challenge that we don't have an answer to. Of course, you'd be more comfortable with a safe biologic than an ongoing JAK inhibitor. But in arthritis and other immune-mediated inflammatory diseases, there's long exposures to JAK inhibitors. So maybe it's not completely unthinkable, but it's something that really requires a lot of thought. And particularly if we're talking to children and their parents under 12, those are important counselling. I normally have 2 or 3 counselling sessions before we'll use an off-label drug, so it makes people understand that it's off-label, understand what the percentages of regrowth are, understand what the consequences of stopping. Because sometimes, and all of you who look after or live with alopecia will know that it's a horrible thing to lose your hair. It's doubly horrible to regain your hair and then lose it again. It's like a second insult, and it's really a horrible thing. So the exit strategy is super important with these drugs and with these long-term follow-up trials. They're going to be really important to have in particularly in kids, very long follow-up, and the safety signals are going to be very important too. So the drug development piece requires a very long follow-up period. So I want to thank you for your attention. We're coming to the end of just before the break, isn't that right? So no, we've one more. We've Leon. How could I forget about Leon? So Benji's going to introduce Leon, and I'm going to finish. Sorry, Leon.
All right, it's my pleasure to introduce Dr. Leon Kirchik, who's clinical professor at Icahn School of Medicine, Mount Sinai, and adjunct clinical associate professor in dermatology at the Indiana University School of Medicine. He's the medical director of Derm Research PLLC, Physician Skincare LLC, and Skin Sciences PLLC. He's been the principal investigator of innumerable clinical trials across the range of dermatology, has authored many papers, lectured nationally and internationally, and really is a true expert on conducting clinical trials, enrolling, and we're very fortunate to hear from Dr. Kirchik.
Thank you. Thank you, Benji, for that nice introduction. So for the next 15, 20 minutes or so, I'm going to be discussing the nuances in different clinical studies. And you know, we heard from the previous speakers all about different studies, different drugs, and different results. Should we compare them? right? As a human nature, we compare everything. I have two sons. I compare them always. Aram did this. Charlie did that. You know, I have a brother. My parents always compared us. But we are different people. Is it really fair? Unless the head-to-head study exists, all those different studies, should we compare them? That's what I'm going to be discussing the next couple of minutes. That's my conflict of interest statement. I do a lot of clinical studies. Therefore, I do receive funding from several different pharmaceutical companies, including those I'll be mentioning today. So let's think about it. Clinical studies are really, really important, right? Number one, that's how we decide who to treat with, what to treat with, what are the side effects, what are the efficacy results, and then also third-party payers, the governments, depending on where you are, they make their decisions looking at those results. But not on all phase 3 or registration trials are created equal. So if you're going to remember anything from today, please remember that you should not compare those trials because they are not head-to-head trials, right? It's really important. Why is that? We're going to go and dissect the study design. Demographics, we have disease state, we have clinical trial design, we have statistics, the way it's presented. Demographics, right? Let's think about it. AD study. Is it the same if I have a clinical study site at North Dakota, Fargo, and you're doing a study for AD in wintertime versus in Miami? You know that in Miami, with the nice and humid weather, AD patients are going to do better than in North Dakota. How about the people, the population? If I'm doing a study in Brooklyn, New York, or Miami, where I have a lot of diversity, different types of patients, different types of skin colors, versus in Green Bay, Wisconsin, when you're going to have only white people. So again, there are differences in the population, in the demographics. Disease severity. Let's think about that for a second. How come we have no systemic trials, systemic drug trials for mild patients? You think that the mild patients are milder and easier to get them better. So we should have more mild patient studies, but we don't. Why is that? Because there is a reason, there's a trick. If what happens is, when you look at the FDA guidelines, the success on IGA is always clear, almost clear. It used to be or, now it's and, 2-grade improvement, right? And 2-grade improvement. Well, if you put moderate patients, well, they're gonna become almost clear. Now you kill 2 birds with 1 stone. You have 2-grade improvement and you have almost clear. You put mild patients, guess what? Even if they become almost clear, they have only 1-grade improvement. That patient is a loser in that study. That's a treatment failure, even though they are almost clear. And in real life, that patient is gonna be a happy camper. Even topical studies, when we put mild patients, they put a quota on it. Only 20% of the whole patient population, usually they want mild, because they are afraid that if you put a lot of mild people, they can become almost clear and it will be all study failure. So there are a lot of tricks and nuances in those study designs. Then the study population, right? 18 years of age and older, and always there is, you see this, this condition, not adequately controlled by topical medication. What the hell that means? Nobody is adequately controlled with topical medication. It's a chronic disease, right? Then you have the age indication, right? 18 and above. So we start always 18 and above. That's what FDA wants. You don't kill anybody, then you go to the next category, 12 to 6, then 6 to 2, 2 years of age to 6 months. Now, Dupi has been approved for all the way down to 6 months, right? Do you know how many patients were there in that age group? 6 months to 2 years of age. Any idea? Natasha is shaking her head. Do you? 11 people. Out of that 11, 6 was on placebo, 5 on Dupi. Now, I have done acne studies that I had people from 9 to 12, 20, 25 people, and FDA said, oh no, you don't have enough people. They approved the acne drug from 12 and above. So don't expect any reasonable behavior from our government. How about the washout, right? You need to have a washout. In some studies, phototherapy, for example, in 6 weeks, and topicals are 2 weeks. In some studies, it's 4 weeks phototherapy, 1 week for topicals. So if you stop the topical steroids, let's say, 2 weeks before you do baseline, what's going to happen? Those people are going to flare. And you're going to have a flare right when you start your study. So then they always want naive patients to IL-4 or IL-13. Good luck finding one nowadays. And then they have easy, the usual criteria is always body surface 10%, IGA of 3 or 4, and then EASI is 16 or above. Finally, we can't find EASI 16 and above. So what do you do? So they lower the thing to EASI 12. So now we have some studies, we have some drugs in the market that has been approved with EASI 12 and above, and some with EASI 16 and above. Rescue medication. This becomes a big deal. When do you give the rescue medication to the patients? Most studies do it after the placebo-controlled period because, right, there are people who are on the placebo, so they're going to require rescue. If you give the rescue, they're going to be a treatment failure right from the get-go. So if you say that, oh, well, if the patient needs rescue from day one, you're going to have a bunch of treatment failures, study failures, because once they get the rescue treatment, they are study failures. And that happens quite a bit. So you're going to decide when you're going to give that rescue treatment. Are you going to give it the first 16 weeks, placebo-controlled period, or afterwards? So if you give it during the placebo-controlled period, you're going to have a lot of treatment failures, a lot, right? Then atopic derm is a chronic disease, right? Everybody shows you the results at week 16. Who cares what goes on at week 16? I care what goes on at year 1, year 2, year 3, year 4. We don't have a cure. It's a chronic disease no matter what. So this is, for example, tralokinumab study, and I like to use it as an example because they never listened to advice, and they gave the rescue treatment during the placebo-controlled period. And when you look at the results, their IGA at week 16 is 16%. But when you go and look at actually long-term, right, at 3 years, 36 weeks, NRI results, look there, EASI 90 is actually 53% and EASI 75, 75%. It's pretty amazing result. But they look horrible when you look at week 16 results. Now, so what efficacy outcomes are we using? Mostly, right, during the clinical trial, IGA. IGA is very tricky. FDA wants you to walk into the room and look at that patient and eyeball. That's really the IGA, right? And then you do the body surface area, and then you do the EASI. Because IGA should be like a gestalt. And you know what? If you're in a bad mood that morning, your gestalt is going to be bad. It's so subjective. It really is. And you should not go back and thinking what the patient's IGA was last week or last visit, because it has to be static at that particular moment. You should not be comparing. The other problem with IGA, it contains lichenification. Let me tell you, lichenification, especially in darker skin, ain't easy to get rid of in a month or 2 or 3. It's very difficult to get rid of lichenification. So IGA results, hard to get 100% clear. All right, let's talk a little bit about EASI. So it reminds me of PASI. The problem with EASI, it takes a little bit more objective. There is more math going on, but it drives me crazy, and I'll tell you why. So when you look at the characteristics of the erythema, edema, excoriation, lichenification, right, the scale is from 0 to 4. So 0 is clear, mild is 1, 2 is moderate, 3 is severe. Now, remember, what's the scale for IGA? 0 to 4, and 0 is clear, 1 is almost clear, 2 is mild, 3 is moderate, 4 is severe. What happened to almost clear in the EASI scoring? There isn't one. So what are you going to do now? What happens to almost clear? It's going to go to mild. What's going to happen to moderate? It's going to go to severe. So those two scales never, ever match. It drives me crazy. Every time I do it, and I do it 10 times, it still drives me crazy. because they will not match. It gives me a seizure. It makes me dizzy because you want it to match, but it won't match, right? So that's why your IGA and EZ75, EZ90 never truly matches. It is what it is. Okay, we're gonna jump to alopecia areata. So I think this is the SALT score. Now is another one, right? It's not easy to calculate those things, by the way. Do you think anybody does this in real life? Once I asked this question, I was giving an acne lecture, and I said, does anybody really count pimples in real life? They should be crazy. And somebody did raise his finger. I was so embarrassed. But the SALT 20 is the primary endpoint, right, in the alopecia areata studies. Now let's take a look. You have mild alopecia, moderate, and severe. The severe is 50% to 100% hair loss, which is always the inclusion criteria so far in every study. But what happened to severe, very severe alopecia when it's 95% to 100% hair loss? What happened to alopecia totalis? What happened to alopecia universalis? So we already have 3 approved drugs in America, right? And the first one was baricitinib that you already heard. On that study, let's take a look. Primary endpoint is 36 weeks, remember, right? Here is 36 weeks. And then your inclusion criteria is 50% or more. But look at the current episode of alopecia areata. You remember Natasha mentioned that 4 years is the key here. And this was all the way up to 8 years. Depending on the study, that number is gonna change. So you're gonna have difficulty treating those patients if they have more than 4 years of current episode. Here is it gives you the numbers, and you see it's all different numbers. The same thing for ritlecitinib. Now look what happened. Primary endpoint is 24 weeks. Current episode of hair loss is up to 10 years. So this is 10 years. The primary endpoint is 24 weeks versus baricitinib. Did they pick a higher, more stringent endpoint? Right, shorter amount of time, more people with 10 years. So it's all those things makes a difference, right? And if you remember, somebody showed ritlecitinib numbers, it was lower than the Barry numbers. That's because their primary endpoint is 24 weeks versus 36 weeks. And they had more people with severe alopecia there, or alopecia totalis universalis, 46%, right? Those are more difficult patients. How about duroxolutinib? Now, they had also week 24 here, but look here, it's now also 6 months to 10 years. But if you look at their mean numbers, it's not that many. They mostly have 3.9 to 4 years of people with the last episode of disease, right? So they picked the sweet point there, 4 years. So it all depends on what you're treating, who's in the study. So for alopecia areata studies, those are the things that will make a difference. Time to the primary endpoint, percent of patients with very severe AA, right? 95% or to 100% loss. People with alopecia totalis and universalis. Eyebrow, eyelash loss, they are always difficult. Duration of disease history, duration of the present episode, concomitant medication. Sometimes they keep people on minoxidil if they are on a stable dose. So all those things will make a difference. That's why you should not compare those patients. Finally, I want to touch upon a little bit of statistics. But before I do that, does anybody know who this guy is? He is Benjamin Disraeli. He is the very first Jewish prime minister under Queen Victoria. He served as a prime minister twice. Why is he here? Because this is what he said. There are lies, damn lies, and statistics. When the drug reps come and show you the numbers, they are not lying, but they can show you in many different ways. It's like this. I can show you my hand. This is my hand, right? But I can show you like this. This is my hand too. Doesn't look the same, does it? So what's the most important part in statistics? The missing data. How do you account for the missing data and why? So intent to treat will take everybody into account in the part of your denominator, no matter how many people finished the study, right? You started 100 people, 50 people finished the study, you still have to count your denominator as that 100 people. But there are different ways of counting those 100 people. One is last observation carried forward, meaning that, let's say somebody did not make the last visit week 16, they came on week 12, and they had EASI 75, so that EASI 75 goes on and they count that as EASI 75. Or it can be what we call non-responder imputation. It doesn't matter if the patient was 100% clear at week 12, but at week 16 they didn't show up on the last visit, they are considered losers. That patient is a treatment failure with non-responder imputation. Is it fair? We're not discussing what's fair, what's not fair. I'm just telling you the way it's done. Now, how about as treated per protocol? Oh my God, that's the best way of looking at the data. If you want to make your data look good, this is how you do it. Why? Because they don't take into account who started. We started with 100 people, but they will not take that into account. They will take only the people who finished. So your denominator is only 50, right? If your denominator is a smaller number, your overall result is going to look much, much better. Study. This is actually adalimumab study, the original adalimumab study. So this is a 120-week study, and we started with 92 people. We finished at 49 people. If I do ITT, right? If I do ITT, look at the green line. Your PASI 75 is almost 78%. I'm sorry, if I do as observed, your PASI 75 is 78%. If I do ITT, your PASI 75 is 41%. Big difference. People will come and tell you our PASI 75 at week 20 is 78%. It's not a lie, but that's as observed. You better ask what kind of analysis they used. Versus ITT is 41%. It's almost half. So now you can say that this guy is crazy. Who cares about the people who didn't finish the study, right? They don't count. They should not be counted. Let's think about it for a second, but before we think about that, why do people get into the studies? People get into the studies, first of all, they are hopeless, they can't get a drug. We pay them really well to come. They get free drug. We treat them really well. You know, I see about 80 people a day, usually spend less than 5 minutes in the real clinic. When I do studies, we spend a lot of time. They get treated really, really well, the study patients, right? So why would they drop out of a study? Unless they drop that, number one, that's going to be really bad. Number two, it doesn't work, the drug, so they don't want to be a guinea pig for nothing, or they have side effects. Now you can say, hey, people move out from one city to another. Guess what? Those are all multi-center studies. If I'm doing a study in Kentucky, somebody is doing it in New York, somebody is doing it in Chicago, somebody is doing it in LA, so they can find another study center that they can continue their study. So that's really not a good excuse. So let me ask you this, and then you'll answer why should we include those people or not. You're giving a dinner party. There is about, 6, 8 people, right? At the end of the dinner party, you guys don't you wanna know how was the food? How was the party? Is everything okay? You wanna ask those all 8 people. But what if already is puking, going away to the bathroom? And the other one just left and could not even get home. Do you wanna ask those 2 people how was the dinner? Or you just want to ask the 6 people who are left in the house, in the dining room? So it's exactly the same idea. So you do want to ask everybody. So that's why always NRI is the best way, not as observed. Okay, clinical trials don't reflect real life. The clinical trials are done to get the drug approved, right? Because look at this. This is a lot of body surface area, but it's not the IGA of mostly mild. And then this is a 2-3% body surface area with severe disease. In real life, we use body surface area as a measure, right, to give a systemic drug. Even in US, all third-party payers, they want 10% body surface area or more. So the problem is what we do in clinical trials that every day I do doesn't really reflect what I do in real life. Patients don't care what the study EASI score is. All they care about their own EASI score. So another way of looking at results is what we call waterfall drug. This shows every single patient. This is again from tralokinumab, by the way. And you see that above the x-axis, everybody did well. Maybe they didn't get into EASI 75, but everybody did well compared below the x-axis, 10, 12 people out of the 300 people. That's what patients care about, their own numbers, how they're gonna be doing, not about the means or the averages or the medians, right? So at the end of the day, statistical analysis is used to demonstrate that the findings are just not due to chance, but statistical significance against placebo doesn't really translate into clinical success. Years ago, there was a fungus drug that we had. It had 5% IgA clearance versus 1% against placebo, so it was approved. You think 5% for onychomycosis is gonna work? It didn't work, but it was approved, and we were using it like bread and butter because there was nothing else. So clinical trials are not clinically relevant always, but still, double-blinded randomized phase 3 trials are still the gold standard because we have nothing else. So in the absence of nothing else, we still use them. And so you shall not compare those studies, but please analyze them. I thank you so much. This is where I was hiding during COVID. Sometimes I remember those days. I actually missed those days, right? I didn't go to work. So I thank you so much for your attention.
I think due to time, we will conclude this hopefully impactful session, and primarily impactful because of the patients. I want to thank our courageous children that participated and their parents, and courageous adults. I know it's not easy to come forward and talk about the disease. It's very emotional. And I want to also thank our clinical trial fellows for their amazing work. And I want to thank all of you for your attention. Thank you so much. And our speakers. Thank you so much for the speakers.
I think there is also a session evaluation, if you can take 2 moments.